What if I told you there's a way to slow down kidney disease that didn't exist just 5 years ago? Not one way, 4 different approaches, and when you combine them, they can significantly change your trajectory. I'm Dr. Sarah Martinez. I'm a nephrologist, which means I specialize in kidney disease. I've been doing this for 22 years. If you or someone you love has chronic kidney disease and you're wondering what can actually be done to slow it down, this video is for you. Because the landscape has changed, and I want to make sure you know about it. Let me tell you why this matters so much to me personally. For the first 17 years of my career, I had basically one tool in my toolbox to slow kidney disease progression. Just one medication class. I would see patients every 3 months. We'd check their labs, adjust their blood pressure medication, talk about reducing salt, and then we'd watch their kidney function slowly decline anyway. It was frustrating for them. It was frustrating for me. But in the past 5 years, everything has changed. We now have 4 distinct categories of medications. Each one works differently. Each one protects your kidneys through a different mechanism. And the research shows that when you use them together, you can slow kidney disease dramatically. In some cases, you can nearly stop the progression. This isn't hype. This is based on large clinical trials, thousands of patients, real data. Here's what we're going to cover in this video. First, I'll explain the foundation medication, the one we've had for 20 years. You need to understand this one because everything else builds on it. Then I'll introduce you to the 3 newer medication categories. I'll explain how each one works in plain language. No jargon unless I define it first. I'm going to share 2 patient stories with you, Robert and Linda. Same diagnosis, same starting kidney function, but very different approaches to treatment. Their outcomes were dramatically different, and I think their stories will help you understand why acting now matters. I'll give you specific questions to ask your doctor, not just talk to your doctor. I'll give you the actual script. And I'll cover the important safety information you need to know. By the end, you'll understand your options. You'll know what's possible. And you'll have hope. Because that's what these medications represent. Real, tangible hope. Let me start with the foundation medication. The one we've relied on for about 20 years. These are called ACE inhibitors, spelled ACE, or ARBs, spelled ARB. I know those names aren't helpful. Let me explain what they actually do. Think of your kidney as a coffee filter. Blood flows through this filter constantly. Waste gets removed. Clean blood goes back to your body. Now, when you have high blood pressure, it's like turning up the water pressure hitting that coffee filter. Too much pressure damages the filter over time. ACE inhibitors and ARBs do 2 things. First, they lower your overall blood pressure. That's the obvious part. But second, and this is the clever part, they specifically reduce the pressure inside your kidney's tiny filtering units. There are about 1 million of these filtering units in each kidney. It's like they turn down the pressure at the filter itself, not just in the main pipe. These medications have names that end in pril, like lisinopril or ramipril, or they end in sartan, like losartan or valsartan. If you're currently taking blood pressure medication, I want you to pause this video right now. Go check your pill bottle. Look at the name. Does it end in pril or sartan? If yes, you're already on one of these kidney-protecting medications. That's good. These are still essential today, still the foundation. Everything else I'm going to tell you works with these medications, not instead of them. So that's tool number 1. Blood pressure control with these specific medications that directly protect your kidneys' filtering units. Now let me tell you about a patient named Robert.
Robert walked into my office 3 years ago. He was 68 years old, retired postal worker, had delivered mail for 35 years. He had type 2 diabetes that had been diagnosed about 12 years earlier. Robert's kidney function had been declining slowly, not dramatically, but steadily downward. His labs showed what we call his GFR, which stands for glomerular filtration rate. This is the number we use to measure how well your kidneys are filtering. Robert's GFR was 42. Let me explain what that means. Normal GFR is over 90. If you're under 60, you have chronic kidney disease. If you drop below 15, you typically need dialysis. So Robert at 42 wasn't in immediate danger, but he was definitely heading in the wrong direction. He was already on blood pressure medication, one of those ACE inhibitors I just mentioned. He'd been taking it faithfully for years, and his kidney function was still getting worse, about 3 to 4 points lower every year. At that rate, we were looking at dialysis in maybe 7 to 10 years. Robert asked me something I hear all the time. "Dr. Martinez, is there anything else we can do? I really don't want to end up on dialysis." 3 years ago, my answer would have been limited. Keep controlling your blood pressure, watch your diet, monitor your labs, hope for the best. But this was 3 years ago, right when the new medications were becoming available and proven. So instead, I said yes. There is definitely something else we can do. Let me pause Robert's story right there, because to understand what we did, you need to know about the 3 newer medication categories. I'm going to take about 6 minutes to explain these. You might want to grab a pen and paper. This is the core information. The second tool, SGLT2 inhibitors. These medications have names ending in flozin, dapagliflozin, empagliflozin. SGLT2 stands for sodium glucose cotransporter 2, but nobody calls them that. We just call them flozins. Here's the interesting story behind these drugs. They were originally developed as diabetes medications. They work by making your kidneys dump extra sugar into your urine. Seems simple, right? But then researchers noticed something unexpected. Patients taking these drugs weren't just controlling their blood sugar better. Their heart failure rates were dropping. Their kidney function was staying more stable. So they did specific studies on kidney disease, and they discovered something remarkable. Whether you have diabetes or not, these medications protect your kidneys. Let me give you an analogy. Your kidney is like a factory that runs 24 hours a day. When some of the factory is damaged, the remaining parts have to work overtime to compensate. The flozins reduce that workload. They take some of the stress off your kidney. They let it work at a more sustainable pace. The studies show these medications reduce the risk of kidney function decline by 20 to 30% compared to taking nothing. That's significant. And here's something I tell my patients when I prescribe these. Some people worry because they know these started as diabetes drugs. They say, "But Dr. Martinez, I don't have diabetes. Won't this make my blood sugar too low?" The answer is no. These don't cause low blood sugar in people without diabetes.
Your body has safeguards. The third tool, Finerenone. This one is newer. Most people haven't heard of it yet. Some pharmacists are still learning about it. The technical name is a non-steroidal mineralocorticoid receptor antagonist. Even I don't say that full name. It's quite a mouthful. Here's what Finerenone does in simple terms. Your kidney can be damaged through different pathways. One major pathway involves a hormone called aldosterone. When aldosterone is overactive, it causes inflammation and scarring in your kidney tissue, like rust building up in pipes. Finerenone blocks that specific pathway. It's like applying rust prevention to your pipes. Now, here's where I want to share something interesting from my own practice. Last year, I had a patient, a woman named Dorothy, who was hesitant about adding another medication. She said, "Dr. Martinez, I'm already on so many pills. Does this one really make a difference?" I showed her the study data. In patients with diabetic kidney disease, Finerenone reduced progression risk by 15 to 25%. But it also did something else. It reduced heart attacks and strokes. Dorothy thought about it and said, "So this helps my kidneys and my heart?" Yes, exactly. She decided to try it. 6 months later, her protein levels in her urine had dropped significantly. That's a sign the kidney damage is slowing down. She's still on it today. Let me quickly recap these first 3 tools before I tell you about the fourth one. Tool 1, ACE inhibitors or ARBs for blood pressure and direct kidney protection. Tool 2, SGLT2 inhibitors, the flozins, to reduce kidney workload. Tool 3, Finerenone, to block the inflammation pathway. Each one protects through a different mechanism. That's why combining them is so powerful. Now for the fourth tool. The fourth tool, Semaglutide. You might already know this medication by its brand names: Ozempic, Wegovy. Yes, the weight loss medication that's been all over the news. But it turns out Semaglutide does more than help with weight and blood sugar control. It also protects kidneys. A major study published last year looked at patients with type 2 diabetes and kidney disease. The study was called the FLOW trial. They included 2 groups of patients. Some had low GFR with just a little protein in their urine. Others had higher GFR but significant protein spillage. In both groups, semaglutide reduced the risk of kidney function decline by about 20 to 25%. Now, I want to be clear about something. This medication is currently being used primarily in people who have diabetes. The studies in people without diabetes are still ongoing. We're waiting for that data. But if you have both diabetes and kidney disease, this is another tool we can consider. So let me recap all 4 tools now. 1. ACE inhibitors or ARBs, the foundation. 2. SGLT2 inhibitors, reduce workload. 3. Finerenone, block inflammation. 4. Semaglutide for patients with diabetes. When you combine these medications, the protective effect multiplies. You're not just adding protection, you're creating layers of defense. Now, back to Robert. 3 years ago, when he asked me if there was anything else we could do, I started him on an SGLT2 inhibitor first. He was already on his ACE inhibitor. We added the flozin. 6 months later, his labs looked stable. We added Finerenone. And because Robert had diabetes, about a year after that, His endocrinologist started him on Semaglutide for his diabetes management. So over the course of about 18 months, Robert went from 1 medication to 4 medications, all working together to protect his kidneys. Here's what happened to Robert's kidney function over 3 years. Before we started the new medications, GFR of 42, declining 3 to 4 points every year. After 1 year with the SGLT2 inhibitor added, GFR of 41, almost completely stable. After 2 years with Finerenone also on board, GFR holding at 40. After 3 years with all the medications, GFR of 39. Let's do the math together. In 3 years, Robert lost 3 points of kidney function, instead of the 9 to 12 points he would have lost without the new medications. That's slowing his progression by about 75%. But more important than the numbers was what Robert told me at his last appointment. He said, "Dr. Martinez, for the first time in years, I'm not constantly worried about ending up on dialysis. I feel like we're actually fighting this thing now, not just watching it happen." That emotional shift matters as much as the numbers. Robert feels like he has some control, some agency. And that changes everything about how you live with a chronic condition. Now let me tell you about Linda. And this story is harder to tell. Linda came to see me 2 years ago. She was 73 years old, retired teacher. She had kidney disease, but no diabetes. Her GFR was 35. She had significant protein in her urine, which is a marker of kidney damage. I explained these new medications to Linda. I showed her the research. I told her what we could potentially prevent. But Linda was skeptical about medications. She'd read about side effects online. She was concerned about taking too many pills. She said, "Dr. Martinez, I'm already on blood pressure medication. Can't we just stick with that and see what happens?" I respected her choice. It's her body, her decision. My job is to inform, not to pressure. But I also told her, honestly, if we wait and your kidney function declines, we can't get that back. The damage is permanent. She said she understood. She wanted to wait. I see Linda every 3 months for monitoring. Over the past 2 years, her GFR has gone from 35 to 27. She's lost 8 points in 2 years. And at 27, we're now in the range where we need to seriously start talking about preparing for dialysis. At her last visit, Linda asked me, "Dr. Martinez, is it too late to try those medications now?" I told her the truth. It's never too late to start protecting what kidney function you have left. We're starting her on an SGLT2 inhibitor next week. I'm hopeful we can at least slow things down from this point forward. But I'm also honest with her. If we had started 2 years ago when she first came to see me, her kidney function would almost certainly be better than it is now. We've lost 2 years, and those 2 years represented kidney function we can't recover. Linda knows this. She said to me, "I wish I hadn't waited." I share Linda's story not to criticize her choice, but to show you that timing matters. The earlier you start protecting your kidneys, the more kidney function you preserve. So here's what I want you to do with this information. If you have chronic kidney disease, I want you to have a conversation with your doctor. Not just a general conversation, a specific one. Here are the exact questions I want you to ask. You might want to pause the video and write these down. Question 1. Am I currently on an ACE inhibitor or an ARB for kidney protection? If yes, good. That's the foundation. If no, ask, would one of those medications be appropriate for me? Question 2. Based on my current kidney function and my medical history, would I benefit from an SGLT2 inhibitor? These are the flozins I mentioned: dapagliflozin, empagliflozin. Question 3. Have you considered Finerenone in my case? This one is newer, so some doctors might not be as familiar with it yet. But it's worth asking about, especially if you have diabetic kidney disease.
If you have diabetes, question 4. Would semaglutide be appropriate for me, both for diabetes management and kidney protection? Write down your doctor's answers. Ask for clarification if something doesn't make sense. These medications are generally well tolerated. Side effects are usually mild, and the benefits, based on the research, far outweigh the risks for most patients. Now, I know some of you are worried about cost. These are newer medications. Some of them can be expensive. Here's what I tell my patients. Talk to your doctor about generic options when available. Ask about patient assistance programs. Most of the pharmaceutical companies have programs for people who can't afford their medications. And the SGLT2 inhibitors and Finerenone are now covered by most insurance plans, including Medicare Part D for kidney disease. Don't let cost keep you from at least having the conversation. Here's what you should absolutely not do. Do not stop any of your current medications without talking to your doctor first. These kidney-protecting medications work together synergistically. Stopping one can reduce the benefit of the others. Now I need to cover some important safety information. This is the part where I put on my serious doctor voice. These medications are not appropriate for everyone. If your kidney function is very low, below a certain GFR threshold, some of these medications may not work effectively or may not be safe. Your doctor will check your labs first. The SGLT2 inhibitors can increase the risk of urinary tract infections and yeast infections in some people. Stay well hydrated. Watch for symptoms like burning with urination. Finerenone can affect your potassium levels. You'll need blood work to monitor this. High potassium can be dangerous, so this monitoring is important. Semaglutide can cause nausea, especially when you first start. This usually improves over the first few weeks. Seek immediate medical attention if you experience severe swelling in your legs or face, difficulty breathing, confusion, severe fatigue, a significant decrease in urination, or blood in your urine. These could indicate acute kidney injury or other serious problems.
And let me be crystal clear about one important thing. These medications slow kidney disease. They do not cure it. They do not reverse damage that has already happened. Think of them like brakes on a car rolling down a hill. They slow you down. In many cases, they can stop you. But they don't make the car roll backwards up the hill. The damage you already have is permanent. But we can protect what you have left. This information is educational. It does not replace your doctor's advice. Every person's situation is unique.
When I started in nephrology 22 years ago, I used to tell patients with kidney disease that our main goal was to keep them off dialysis as long as possible. We managed symptoms, we monitored labs, and mostly, we waited. I hated that part of my job, the waiting, the watching, the feeling helpless. Today, I get to say something completely different to my patients.
Our goal is to actively protect your kidneys, to use every tool we have to give you the best possible chance of preserving your kidney function for as long as possible. Remember at the beginning of this video when I said we went from 1 tool to 4? That's not just numbers on a chart. That's not just medical progress. That's hope. That's possibility. That's you having real control over your health journey. If you have kidney disease, you are not just a passenger on this ride. You're not helpless. There are proven, effective things that can be done. Medications that can genuinely change your trajectory.
Talk to your doctor. Ask those specific questions I gave you. Understand your options. You deserve to know what's available. You deserve to make informed decisions. And you deserve hope. If this information was helpful to you, I'd really appreciate it if you'd subscribe to this channel. I make videos like this because I want people to understand their health conditions. I want you to walk into your doctor's office informed and empowered. Click that subscribe button below. Turn on the notification bell so you don't miss future videos. And here's something important. If you know someone with kidney disease, share this video with them. Send them the link. Post it to your social media. This information could genuinely change someone's trajectory. It could add years of healthy kidney function to someone's life. That's not an exaggeration. That's what the research shows. You can also comment below if you have questions. I read through comments regularly and answer when I can. I can't give specific medical advice online, obviously, but I can address general questions about kidney disease and these medications. And one more thing. Next week, I'm releasing a video about diet and kidney disease. What actually matters and what's just noise. There's so much confusion about protein, sodium, potassium. I want to clear it up once and for all. Make sure you're subscribed so you don't miss that one. Thank you so much for watching. Thank you for trusting me with 26 minutes of your time. I know that's not a small ask in today's world. I hope it was worth it. Remember, you are in charge of your health, but you're not in this alone. I'm Dr. Sarah Martinez. I'll see you in the next video.